for preparing my talk, I had to do a lot of research and lot of study. I did a lot of reading because the topic is such that historical and current perspective. What was the treatment of diabetes then and what is the diabetes now? Will you share my screen? My slides are to be shared by you. Can you share my slides, please?
Okay, sir.
Please share my slides. I'd already sent them. Yeah, that's right. Now, diabetes management has really evolved. And you'll realize that diabetes word was coined by, next slide please, was Apollonius of Memphis. And what it means to go through or siphon. A disease drained more fluid than a person could consume. And mellitus is a Latin word for honey, added to diabetes because of the urine was sweet. Interesting. Next slide, please. Now, India.
Sir, you have also right to changing the slides.
I have a right to?
Yes, to change the slides.
Okay. But I don't know how to do it.
No, only just
Okay, I'll try. In India, Hindu healers wrote that flies and ants were attracted to urine of people with mysterious disease that cause intense thirst and urine output. In 1774, Dobson confirmed sugars in the urine. In 1869, Paul Langerhans, the great man, identified the mysterious cells of Langerhans. 1909 to 1910, the name insulin, because it came from islands. So, islands. The word from islands, insulin for the secretion of the cells, coined by Meyer and Schaefer. In 500 AD, Indian physician Sushruta and surgeon Charaka identified the two types, later named them type 1 and type 2 diabetes. In 18th century, English doctor found that diabetes occurred in people who had experienced an injury to the pancreas. In 19th century, no effective treatment and fatality within weeks and 10 months first showing symptoms. Jocelyn had written, a time prior to insulin, physicians were just counting the number of days the child would die. Banting and Best and the Collip established deficiency of insulin as a cause of diabetes. Next slide, please. I don't think I can move from my end. Yeah. Now, the impact of insulin on life expectancy by 1940, age at start of diabetes was 10. Average age of death in 1897 was 11 and 3 years, 11.3. Average age in 1945 was 45, and years gained, 34 years, people lived longer. Next slide, please. Yeah. 1678 to 1977 was a journey of Thomas Willis tested his patient's urine to establish honeyed urine. Then the urine strips came in 1960. The things became very easy. I remember in 78 when I joined medical college, 71 actually. At that time in the ward, we used to do the Benedict solution, boil the urine with Benedict solution. It was so cumbersome and quite a few times only urine testing was done. In 1969, automated do-it-yourself glucometer, great journey we reached, people started checking their own sugars. Boston researchers developed a test to measure glycosylated hemoglobin, and 1977 was the era of. Next slide, please. Insulin resistance and beta cell dysfunctions are two core defects in type 2 diabetes. Look at the seesaw. Glucose oxidation, glucagon synthesis, enhanced fat synthesis, increased protein synthesis, then the glucolysis, and then glucogenolysis and ketogenesis. These are the features. The genetic susceptibility, obesity, sedentary lifestyle all aggravated, which is a typical Indian phenotype as insulin resistance and beta cell dysfunction, which became complete, resulted in type 2 diabetes. Next slide, please. Now the came ominous octet, Art Shatru, the decreased insulin effect, increased lipolysis, increased glucose reabsorption, decreased glucose uptake, neurotransmitter dysfunction. People suddenly realize that brain is also very important. Of course, there are so many people in this country are successful where you wonder whether brain is really required. But in diabetes, brain has acquired a lot of importance, particularly hypothalamus pituitary axis. Increased hepatic glucose production. The factory produces too much of sugar. Overproduction of glucose is a feature in type 2 diabetes. Increased glucagon secretion, islet cell failure, and increased insulin secretion in the insulin, decreased insulin secretion, the main physiology which causes problem. Ominous octet. And you see from ominous octet, it went to dirty dozen. From 8 to 12, they found the role of catecholamines, vitamin D, renin-angiotensin system, testosterone, and treacherous 13 is iron now. Iron deficiencies as well as iron excess can cause diabetes. Next slide, please. The classification of diabetes. Next slide, please. The classification of diabetes, type 1 diabetes as immune-mediated, idiopathic. Type 2 diabetes, more than 90% individuals have type 2 diabetes. 10% may have latent autoimmune diabetes of adults, LADA. 1 to 5% may have autosomal dominant inherited form maturity onset diabetes of young. 1% rare genetic mutations, gestational diabetes, and others. Next slide, please. Clustering of type 2 diabetes identified in Indians. We have type 2 diabetes. We have severe insulin deficient diabetes, almost 27%. Insulin resistant obese diabetes, almost 26%. Combined insulin resistant and insulin deficient diabetes is 12%. And mild age related diabetes, almost 36%. So this is the clustering of the typical diabetic that you see in India. Next slide, please. Stages in the natural history of type 2 diabetes: normal, IGT, IFFG. This is known as pre-diabetes. Secondary prevention can happen in a type 2 diabetes, which is a clinical setting. Then comes the stage of a tertiary prevention, which is complication, disability, and death. The first condition is a normal glucose, but they are pre-diabetic, obese. Even hypertension is classified under this. So hypertension also has to be treated with multiple activities, including diet, exercise, lifestyle. Next slide, please. Now, 19th century diet and exercise, 1922 bovine insulin, 1950 sulfonylurea, 1980 was the era of human insulin, and 1982 biosynthetic insulin. Now, the progress in diabetes management is progressive insulin. Cardiometabolic syndrome is under control. Hypertension is under control. And there are some wonderful drugs which have come, which have really changed the life of a diabetic. Next slide, please. Now you see, next slide. Yeah. Now you'll see that there is so much of advances from 1950, and what has come on the top of it is a SGLT2 inhibitors, which has completely changed the treatment idea of type 2 diabetes. SGLT2 inhibitors, the enthusiasm about this product is so good that it is one drug which does three jobs. It reduces volume, contraction of blood volume, contraction of systolic hypertension, and most important, which we all desire, which metformin fails, is a weight loss. And weight loss is not only because of fluid loss. The weight loss is a changing the fatty acid composition in the abdominal and the thin fat Indian, which has a high prevalence of coronary artery disease because of proximity of fatty acid secretion near the liver, which goes easily to portal circulation, and the abdominal girth, which is higher in ratio to BMI. The waist circumference is more than 80 centimeters at the BMI of 20, which is a major risk factor in our Deshi people. Next slide, please. Now, profiles of anti-hyperglycemic medication. Next slide. Next slide. Yeah. This is a very complex slide, but important to know that we have metformin, GLP-1 agonists, SGLT2 inhibitors, DPP-4 inhibitors, alpha glucosidase inhibitor, thiazolidine, sulfonylurea glimepiride combination, Colvsil, BCR-QR, insulin, and Premide. This is the progress of various molecules. At each area where there is a defect, it can be intervened. And now today's problem with us that our consultants as well as our diabetologists have a very wide choice. And that wide choice is usually, sorry to use this terminology, but muscled by pharma industry. Very rightfully, they give a correct presentation, but they can change the prescription style. But most conscientious doctors who are my students and my colleagues, they follow their own principle and they identify the correct defect and use a correct molecule with a lot of benefits. Next slide, please. Metformin and its potentials beyond diabetes also have been recognized. Next slide, please. Next slide. Next slide, please. Yeah. The foundation therapy for all patients with type 2 diabetes is a drug demonstrated efficacy, safety, low cost, and cardiovascular benefits. Now, metformin was one banned drug. America did not use it, so we also did not use it. Then America started singing songs about it. So we certainly realized that besides diabetes, it has got other uses like polycystic ovarian disease and so many diseases now that metformin can be used as an anti-aging drug. It has been promoted. Anti-aging. Some more things will also come up depending on the number of manufacturers of metformin. Metformin is a cheap drug. It can be produce very simple, but its distribution and therefore the drug formulation is increasing because metformin has come under price control. But when you combine with multiple drugs, they will see the combination of metformin with Voglitor, with glimepiride, metformin. There are tons of combinations, but it has a definitely role. One thing it does is can reduce your weight to a certain extent. In my opinion, and differences opinion, because it is differences opinion, my opinion is important. If the metformin after giving for 5 to 6 years fails to reduce weight, it's time that you stop metformin. If the metformin does not reduce weight after 5 to 6 years, you have to look for some other drug. Timeline of modern history of diabetes: 1960, successful pancreas transplant. 1976, the first infusion pump using insulin. 1998, UKPDS trial, organ protection with glycemic control. UKPDS has really opened our eyes about tight control of glycemia. Ongoing islet cell transplantation. Next slide, please. Guidance for industry. Diabetes mellitus evaluating cardiovascular risk in new anti-diabetic therapy to treat type 2 diabetes. Pre-marketing interim outcomes data should rule out hazard ratio of 1.8 for major CV events. Now, today, any new drug has to come, it has to pass the cardiovascular safety trials. And they are very difficult because the amount of money spent on cardiovascular safety can be more than the manufacturing cost of the drug. But it is mandatory after the bad experience they had with rosiglitazone. Cardiovascular safety is mandatory for any new molecule. Meta-analysis of phase 2 and phase 3 clinical trials would be the default option to satisfy these requirements. And this is a very important. Next slide, please. Next slide. Now, type 2 diabetes, evaluating the safety of the new drugs for improving glycemic control. At least 500 patients with stage 3-4 CKD exposed to the new drug. 500 patients of grade 3 to 4 CKD. It's what our Indian patients have. At least 600 patients with established CVDs, established 1 artery block, 2 artery block, angina, echocardiography showing reduced ejection fraction. Previous stroke, peripheral vascular disease exposed to new drug. At least 600 patients older than 65 years of age must be exposed to new drugs. See, these are the guidelines. New draft guidelines not contain recommendation that sponsors of all the new therapies for type 2 diabetes uniformly rule out specific degree of risk of ischemic heart disease. Next slide, please. Next slide. So, diabetes is equivalent to cardio-renal-metabolic disease. Glycemic, because of weight reduction, albuminuria, BP, lipids, CV, metabolic, hyperglycemia, insulin resistance, obesity, dyslipidemia, NAFLD, NASH, cardio, hypertension, hypercoagulation, atherosclerosis, heart failure, acute coronary syndrome, and renal is a before chronic renal failure. The EGFR should not go down more than 50%. Next slide, please. So diagnosis, lifestyle, metformin. With severe renal disease, atherosclerotic heart disease, heart failure, chronic kidney disease, AGLT2 inhibitor, GLP-1 agonist. Without severe renal disease, minimize hypoglycemia, control weight, cost sensitive. So these are the two distinct approaches which I do. This is my funda. The success of my treatment is because I divide them in this form and it works. Next slide, please. Now, RSSDI is a great organization RSDI 20 recommendations, treatment goals for patient with diabetes with severe risk. Patient with diabetes and CV should follow A, B, C treatment goals. A, glycosylated hemoglobin less than 7, BP 130 by 80, cholesterol less than 100. Now this is a tall order, but RSSDI are tough people. They are great physicians. They are very, very authentic people. When their recommendations come, we listen to them. Now, this is the goals of care. Next slide, please. These are the recommended decision cycle for patient-centered glycemic management in type 2 diabetes. And these are our goals. Next slide, please. Artificial intelligence in healthcare. The world has become tech savvy. Why can't we? Now, please remember, artificial intelligence is given in the hands of people who are assumed to have their own intelligence. Try to understand, if the artificial intelligence lands up in idiots, it will be disaster. Luckily, all doctors in our country are smart. Very few are idiots, but most of them are very intelligent and they are very conscientious, and artificial intelligence is a boon. Next slide, please. And this is the digitomes, new techniques, data and artificial intelligence at the services of diabetes prevention, management and care research. A very good landmark for post-graduation. Next slide, please. Future possibilities of artificial enormous. Advanced diagnostics, precision medicine, drug discovery and research, patient remote monitoring, population health analysis, and clinical decision. Next slide, please. Artificial pancreas is a great thing in offering. Next slide. Importance of organized diabetes care. We must have an organized diabetes care. We must have a teamwork. And diabetes in organized setup, like I have Reg Hospital, we do a lot of good work. I'm not saying others are not doing, but this is a role model, and I'm very proud to have initiated and started it. And I am will showcase what is the importance of organized diabetes care. Next slide, please. So diabetes care team, consultant diabetologist, endocrinologist, diabetes specialist nurse, certified dietitians, dietetic educators, certified chiropodist. Next slide. Resources required in diabetes clinic. I think you can just go through this. There are multiple areas. Next slide, please. Sugar is the fifth vital sign. Sugar is the new tobacco. I'm very forceful on that in my cardiac hospital, where we consider sugar is the fifth vital sign. When I talk about it, many of my postgraduates ask me, sir, what are the first four vital signs? Then I had to explain to them what are the vital signs. But sugar and tobacco are equivalent. Next slide, please. Diabetes, pre-diabetes, and diabetes reversal is possible. And that is what we are aiming. Probably last slide for you, because I see Dr. Ram there, Dr. Vinod Kumar there. He had requested me that I should be present. I am eagerly waiting for his talk. And thank you very much